Yeah, so did
Wait,
I. I also asked to Jennifer
yes.
to make a consensus for
Correct.
prolapse.
Yeah. So not just sacrocolpopexy, we can take other procedures as well, like pectopexy, Birch-Kulpa suspension, because we are using robot for all of them. So that will be nice.
Yeah, maybe we can break down the scope of a consensus to a smaller question. We don't have to answer a big question or big consensus. We can break into, so for example, this time ovarian cancer or ovarian tumor, the next time pectopexy or pelvic reconstruction,
That's
to
true.
break down to smaller topics.
Becomes easier.
That will
That's
be
very true.
easier to finish and yeah, more paper to publish, right?
Yes.
And we have to update this every 1 or 2 years, right?
Uh-huh. Okay. So I think we have some of our speakers. Hi, Dr. Kanika.
Ma'am. Hello,
How are you?
everyone. Good evening. How are
Hi.
you, ma'am?
I'm doing well. Thank you for joining in. Let me introduce to some of the people that are there right now. Dr. Kanika Batra is a gynae oncologist here at India in Max Hospital in Delhi. A brilliant surgeon and a close friend, I must say. Let me introduce the three people that I can see on the screen right now. Professor Lai is a professor in Taiwan, and he just was chairperson to do our annual ASGRS meeting, which went on very successful. Dr. Jim Peck is in, see, tell me the hospital, Jim, I forget your hospital.
Aju.
Ajay.
Ajao University. Yes, Ajao University. And he's a professor. He's one of the founder members for ASGRS and has been working very closely with this society. So good to have you as one of the speakers. So I think it's 5 o'clock. Let's begin.
So according to today's agenda, I think next speaker will be Jim. Let me briefly introduce Jim, Ji Hong Pak. Maybe some of our audience online may not be familiar with Jim, although we have been we have been friends for more than decades, for a long time. But let me briefly introduce Dr. Ji Hong Pak. Ji Hong Pak is an associate professor at Aju University School of Medicine, Korea. His specific area of expertise, of course, is in minimally invasive surgery of GYN cancer. And he has performed more than 1,500 cases of robotic surgery and more than 2,000 cases of single-port laparoscopic surgery in gynecology field. So he is one of the founding member of ASGRS, and he currently serves as the education committee chair of ASGRS and also the scientific committee chair of Society of Korean Robotic GYN Surgery. He is now also the editor-in-chief or editor-in-chief of GYN Robotic Surgery Journal, is the official journal of ASGRS and the societies of Korea and many countries in Asia. So if you have anything to publish, welcome to submit it to Jim. Without further ado, let me hand the stage to Jim. He's talk about the robotic surgery for suspicious ovarian mass. Let's welcome Jim.
Okay. Thank you for my introduce me, Hu Cheng. So, hi everyone. My name is Ji-Hyun Baek from Ajun University. So, okay, it's a Friday night. So hopefully, let's do it. And then on other days, Monday, Tuesday, how about this Thursday? Yes, it will be four over of us. So. Anyway, so just kidding. So thank you for giving me share my experience. So can I share? Can I share my presentation file?
Please go ahead. Yeah.
Okay. Okay. Can you see my presentation file?
Yes, we can. And we
Okay.
can hear you
Yes,
well.
yes.
Okay. I will start. And as Hung Cheng talked to us that I'm gonna talk about the robotic management of suspicious ovarian mass. So I don't have conflict of interest. So this is today's information. So I'm in this presentation, I'm using the XI systems, not SP. So port is multi, not single site. So patient was early stage ovarian cancer. So it is key question for my presentation. Before starting my presentation, is robotic surgery feasible in ovarian cancer? Is a very critical point in in this presentation topic because suspicious ovarian mass is a little bit enlist borderline malignancy or cancer. So in other words, we can change the key questions. Can robotic surgery reproduce or replicate the same surgical dissection and results as open procedures? That's very important question to me as well as any other surgeons in oncology field. Because yes, answer is that not always case, but not every patient, not every surgeon. So some expert surgeon do primary debulking surgery in ovarian cancer in advanced stage, but not every surgeons because challenging factors during MIS, including robotic or laparoscopic surgery in advanced ovarian cancer, still remains, including Burkinis of disease, and we can call the location, and we can call mental caking. And then another point in the extent of disease, we call that peritoneal seating or the location of disease. So diaphragm or liver disease, sometimes we can do that, but sometimes we cannot do robotic surgery in advanced ovarian cancer. So the second question is very key question. Is robotic surgery feasible in early stage ovarian cancer? Answer is absolutely yes, because robotic surgery is very useful for peritoneal disease. So we know that ovarian cancer, especially for early stage, is very limited to the peritoneal disease. So robotic surgery will be very useful for early stage ovarian cancer, right? So based on this background, so NCCN guideline as well as ASCO will recommend for selected patients, MIS might be used by an experienced surgeons to manage early stage disease, not advanced stage. But MIS can be used for select patients for interval debulking surgery after neoadjuvant chemo. So ESGO also will recommend the ESGO guideline for ovarian cancer. Just MIS surgery is considered acceptable if performed by an experienced surgeon to manage early stage disease, not advanced stage. So robotic management of suspicious ovarian mass is my today topic. So I can change a little bit little bit things, suspiciously early stage ovarian cancer. I feel like my topic a little bit is overlapped by next speakers, maybe a little bit overlapped, but just I'd like to show my perspective in suspicious preparation for suspicious early stage ovarian cancer. So the most important thing is to balance between minimally invasive benefits and oncologic safety. It's very simple. So if a patient come to us she has a solid mass in the abdominal cavity. So radiology finding, including CT scans or MRI findings, showed that some maybe benign, not benign tumor, just a solid tumor, including um, uh, papillary projection or something like that, and then elevated tumor marker, including CA125 or CA99. So, so in this case, so if we decided to perform robotic surgery, because if there is no evidence of advanced stage, including peritoneal seating or omental kicking or diaphragmatic disease, so if we expect that this patient was expect that maybe she was the early stage of ovarian cancer, so what are you gonna do? So that is my talking today. So very simple steps. So for me or for other surgeons, very simple but very important things because in this case, we have to prepare for staging surgery after proton biopsy. So according to the proton biopsy, we have to change it to staging surgery. Just only sampling oophorectomy after that staging surgery. So we need to put placement for robotic surgery as very important thing. Is so at first time we just or we needed to just sampling oophorectomy, but according to it depends on the proton biopsy, we have to change the staging surgery. So port placement is very important because we cannot change after proton biopsy. So and then we have to focus on the perform the working without tumor rupture. Yeah, of course, because it can uh, uh, sometimes it can be upstaging. It depends on the tumor rupture or tumor spreading after surgery. So very important thing. So my placement for staging surgery, actually it is same to high risk endometrial cancer because yes, I gave you several times in my presentation. I'm using lower pelvic floor placement is very useful for upper abdominal approach compared to other high placement or same level or umbilical level. So very low pelvic placement is very useful for upper level, upper abdominal approach or including diaphragm or some liver or some para-aortic lymphatic metastatectomy or omentectomy is very useful. So I always do lower pelvic placement. Just at first step is of course I will do salpingo-oophorectomy. It means that just remove the tumor, and then I will send the tumor to pathologic department. So I will wait the result, frozen biopsy. After that, according to the frozen biopsy, so if unfortunately if she has cancer malignancy or epithelial ovarian cancer or some cell tumor, so I will do staging surgery. So including hysterectomy or sometimes fertility sparing staging surgery. So and then I boom rotation. After boom rotation, I will do abdominal approach to that. So omentectomy, appendectomy, and peritoneal biopsy and diaphragm area. So it is very useful for a lower pelvic floor placement. So I will show this simple video and then short video and then to perform debulking without tumor rupture, just an early stage or just a suspicious ovarian tumor. Maybe I remember she is very young age, maybe less than 30 years. She has 7 or 8 centimeters in the left side ovarian tumor. Radiology finding MRI showed that maybe ruled out, maybe there was a possibility of epithelial ovarian cancer early stage or just mucinous cysta adeno borderline malignancy. So the first step is very important thing is we have to identify the this side ureter. Where is the ureter? Is very important things because the ovarian tumor, if it is malignancy, maybe it can be attached. It can be maybe to the peritoneum disease. So I will do I will try to remove peritoneum together to the with ovarian tumor. So the first step is where I like to identify where is the this side of this ureter. So I'm doing that. So and then the second step is I'm finding out the where is the adhesion of peritoneum to ovarian tumor. So in this case, very easy, very small pieces, small peritoneum is attached to the left side ovary. So I'm doing the um, left side ureter to laterally, and then maybe I will removing apial ligament and then go peritoneum together. So I'm doing that. So in this case, I'm using the bipolar in the left side and then the right side the progress per forceps. But recently I'm doing I like to use both arms for bipolar forceps, both of arms. And then in this case, I'm using vesicillars. Vesicular expand is very useful for dissection or to identify without the mechanical injury or injury to the peritoneum T of the left ureter. So yes, I'm checking the where is the adhesion peritoneum to ovarian tumor. So I didn't know in this time, I didn't know so it is cancer or not, but just suspicious ovarian cancer or not. So I'm just trying to uh, avoid this tumor rupture. Just I'm trying to remove peritoneum together without detach between the peritoneum to ovarian mass in this case. So I'm doing the always same time, same procedures. So I'm doing the vesicular, using the vesicular to peritoneum removing. So together ovarian tumor. So and the same, so easy, very very easy. So I'm checking the where is the another detaching the attaching the adhesion between any other side and then the pelvic cavity. Fortunately, in this case, there was no any more adhesion in the pelvic cavity. But sometimes we can encounter the severe pelvic adhesion in the pelvic area between the peritoneum and then uterus and then the pelvic side wall. But as I talked to you, um, robotic surgical system is very useful for peritoneal disease. So when we want to remove the or peritoneectomy or peritoneization is very useful for robotic surgical system. That's the point. That's the reason why I can talk to us. Robotic surgery is very feasible in early stage ovarian cancer. So I'm removing the peritoneum together and then ovarian tumor. So we have to be careful to tumor rupture or split. Then so so yeah, it is same. It is same too. Just self-finger oophorectomy is very simple, but anyway, we have to do that. Identify the ureter and then peritonization. So frozen biopsy, unfortunately, she has cancer. Maybe I can remember, maybe or epithelial early stage epithelial ovarian cancer. So there was no evidence of any other disease in the pelvic cavity in the abdominal cavity. So it's just a peritoneal biopsy. So in this case, she has ovarian tumor in the just the left side is located at. So I'm doing the peritoneum resection little bit more. So in the same location because the tumor was located in the left side. So I'm removing the more peritonectomy a little bit. So more just checking the whether there is the evidence of peritoneal disease. It is very simple. Just no lymph node dissection or lymphadenectomy. So I'm doing the removing the little bit peritoneum in the paracolic gutter. So of course, if we do laparoscopically or open procedure, paracolic gutter or some diaphragm or peritoneal biopsy is a very easy procedure, but robotic surgery a little bit something like a structured things. So in this case, I'm doing the lower pelvic floor placement. So it means that I'm using the floor placement in the between ASIS lines. So parabolic gutter is located in the same area in the port placement. It is so a little bit struggling is among dams, but it doesn't matter. So after boom rotation, I'm doing the omentectomy. So I felt like it is just a omental biopsy was enough for not full omentectomy. But if we want to full omentectomy or if we want to infracochlear omentectomy, it doesn't matter because lower pelvic floor placement using that we can enough space or enough target, enough distance from instrument to target, including omentum or diaphragm or liver, as is very easy, much easier than any other placement. So I'm doing the omentectomy using vesicular extend. So it's very useful for those bipolar device. So I'd like to show this the difference peritoneal diaphragmatic peritoneal biopsy between the it depends on the patient position. In this case, so I'm just I leave the patient is a head down position. So very little bit difficult because it is related to the position of the patient. So sometimes if we do approach the upper diaphragm or upper the liver is very, very difficult to things. So in this case, not in this case, but recently I do always do patient position is flat, not head down position. So if patient has flat position, is very much easier than head down position. Regarding this diaphragmatic peritoneal biopsy. So yes, I'm doing the appendectomy. So maybe in other case, maybe she has a mucinous borderline or mucinous intraepithelial carcinoma. So I wanted to remove the appendix. So just incidental appendectomy doing that. So using vessel sealer or just yes, I'm using the vessel sealer is very useful to, and then I'm using the yes, and the what can I call that? And the push. Well, I I cannot remember. Anyway, anyway. Okay. So let me show that little bit difference. So she has flat position, not head down position. So if she has flat position, a little bit much easier than approach to the diaphragm. And then this is the left side is much easier than to compared to head down position. So in the same manner in the right side, and then so surrounding the pelvic peritoneum. So if we do that peritonectomy or just a peritoneal simple biopsy is useful for robotic surgery in just early stage ovarian cancer. But you know that Peter Lim or Hung Cheng Lai will performing the peritonectomy in the diaphragm abdominal procedure. It's a little bit different. So we have to change a little bit for placement of that. But lower pelvic practice is very useful for that. So that's final thought is my presentation for robotic management of suspicious ovarian mass. So one is we have to know the patient is early stage or just ovarian tumor or advanced stage because for advanced stage we have to decide it neoadjuvant chemo is useful or not, or primary debulking is possible or not. We have to decide that. So robotic surgery or MIC is useful. So we have to consider that. So and then the second one is for placements. It means that we need to prepare more optimal procedures, just as well as just salpingoplasty. After that, it depends on the frozen biopsy. We have to perform abdominal optimal procedures in the upper abdominal approach. And then finally, we need to see the possibility of laparotomy. It depends on the patient status. So if we cannot reproduce the same procedure or same results as open procedures, sometimes we have to or we need to consider the possibility of laparotomy. Okay, thank you very much. Thank you all.
Thank you, James. Very short and concise talk about the robotic management of suspicious ovarian mass and focus more on early stage. Yeah, I think I noticed that most speakers, when talk about robotic surgery in ovarian tumor or ovarian cancer, will usually the speaker will cautiously or intentionally narrow down to the scope of early stage, not still a little bit afraid of challenging the full scale of robotic surgery in ovarian cancers. So, so any question from the floor? You can just use your microphone.
Hi, Dr. James.
Yes.
I basically excellent talk, and just a couple of things that I wanted to ask you regarding your experience. So if you basically are dealing with ovarian masses which are large in size, say to the tune of over 15 centimeter or around 15 centimeter, so I have difficulty in using the lower pelvic port in that kind of a situation. So how I have navigated around that situation is that I tell the patient, because most of the times I'm suspecting it to be a borderline, or maybe maybe it could be an early ovarian cancer. So I take the ports above only instead of taking the lower pelvic port. And then for borderline, I managed to do the things with the standard post placement rather than the lower pelvic port placement, omentectomy and multiple peritoneal biopsies. But yes, if it does come out to be an early malignancy, then I tend to put more ports. But with large masses, I have difficulty with the clashing of the instruments, and I don't want to rupture the ovarian mask at any cost. So please, I would like to know about your experience in this.
Yes, of course. Thank you for great comments and then suggestion. So I totally agree with you because yes, for ovarian tumor management, we have to the size of tumor. So regardless of this is borderline malignancy or cancer, so it depends on the patient status. So we have to decide on the MIS, including robotic surgery or not. Otherwise, we have to laparotomy, of course. So using lower pelvic floor placement, yes, I am focusing on just the size in the pelvic cavity, just the size in the pelvic cavity, maybe less than 10 centimeters, maybe around in that. So as you talk to me, 50 centimeters? No, we have to we have to change any other approaches that. Of course,
Yeah.
I totally agree with that. But borderline malignancy is a little bit different. So I mean that patient, for example, she is less than 20 years old, maybe 15 or 17 years old, and then she has 15 centimeters. Radiology findings, CT scan or MRI scan rule out borderline malignancy. So do we have to laparotomy? So I don't think so. Borderline malignancy, just a borderline malignancy is malignancy, not cancer. So in this case, we can choose one of MIS and then MI surgery and just spear and then aspiration of stain and then cystectomy. So it depends on the patient status. Thank you for great suggestion and great comments.
Yeah, thank you. Any further question? Yeah, Jim, I have one question. Everyone worry about rupture, right? but
Mm-hmm.
we usually came across patients with large ovarian tumor, but mostly are cystic and with fluid, right? So what's your opinion regarding to drainage? Then put it in the back, or what's the difference between intentional drain procedure and accidentally ruptured situation? But even open surgery, sometimes it's quite difficult to keep the tumor intact because adhesions for many reasons. So how important is rupture in some situation? What's your opinion?
Yeah. Okay, one more example. So
Uh,
she has 30 centimeters, 30 centimeters ovarian tumor.
yeah.
So if we do laparotomy, so is there any possibility to spill? So I'm not sure. I'm not sure. So it depends on the size. So maybe the radiology finding not obviously cancer. So I can do MIS surgery, just a after aspiration and then go
Mm,
to surgery.
yeah.
Yeah, also on the same note, if I can just add, so a lot of times when we are planning cystectomy for borderline ovarian tumors, say in a young girl who's got solid cystic masses and they want to get a cystectomy done. So, what is the approach that you like to take? Because I prefer to do open surgery for such young women, get the ovarian masses outside of the body, and then aspirate and do the cystectomy, which leads to lesser chances of spillage. So, maybe your comments on this.
Yeah, so it all depends on the decision between after the communication of surgeon and the patient, because some patient prefer to have a cosmetic concern with lower chance of malignancy, but the other example is that the patient just doesn't want to lower the risk of malignancy. She doesn't care about the surgical wound. So it all depends on the communication with the patient.
Yeah, I'd like to make a comment here, which is very true. So, having a suspicious mass and with the uh, advent of minimal access surgery, most surgeons would like to do minimal access surgery as well as patients would like to have it. So, I think the discussion about very controlled aspiration and then proceeding with a cystectomy or even an oophorectomy in a large mass maybe a better controlled way of doing things rather than an accidental rupture. There's no doubt about it.
Mm.
I'm not sure, maybe one of you can tell me if there is any literature to say in a post such situation in the peritoneal wash, because we generally take a cytology at the beginning of the surgery, right? Have
Yeah.
we, do we have any data which says that if there was an accidental or we did a deliberate aspiration, what did the cytology say after that procedure? I'm just raising a point which may be worth considering and looking into,
Yeah, so
Absolutely. The study.
right?
Yeah,
That,
absolutely.
that
I
could be
mean,
that could be a multi-center study, and if
yeah.
it and then we could come to some kind of discussion in a large ovarian mass how to do MIS. Just as thought.
Yeah. And one more question, Jim. And we always say
Mhm.
that some selected patient and experienced surgeon. So my question is, what kind of experience the surgeon need to do this kind of robotic ovarian debarking surgery or suspicious malignancy? What do you think the criteria of a experienced surgeon?
So I feel like experienced robotic surgeon uh, can do change our own practice to laparotomy, any other approach. So of course, we are talking about the number who were experienced regarding robotic surgery, but experienced surgeon can give up during my own robotic surgery to change it to laparotomy or any other approaches. So it's a very important thing because this is ovarian cancer, not benign disease. She has ovarian cancer. It is a very, very critical point to, it is related to the survival outcomes. So we have to sometimes give up the robotic surgery, so or not. So most experienced surgeons, NCCN guideline or ESGO guideline, maybe recommend the experienced surgeon means that is that. Okay.
So do you think the board of GYN oncology is needed for of the surgeon to do the debulking surgery? Is the surgeon has to be the GYN oncologist, or traditional GYN oncologists? They are not necessarily good at robotic surgery, right? So, but when you are doing robotic surgery and came across with the suspected ovarian cancer, so do you just close it to refer to the oncologist, or just do the rest of debulking surgery by yourself, even if you are not a GYN oncologist? What's the situation in Korea? Because I had some experience from a patient from United States when they have ovarian cyst or endometriosis, and do the laparoscopic or robotic surgery, and then the frozen section revealed malignancy, then just close the surgery, then refer it to the GYN oncologist. That in the situation in United States, if the surgeon does not have the GYN oncology board, they have to refer it to GYN oncologist. So what do you think in
Yes,
Korea?
it depends. It depends on the hospital's facilities role or situation. So it depends on the hospital in Korea. So many hospitals different. So in my hospital, so in my clinic, uh, of course, all of gynecological oncologists will perform debulking surgery or MIS. Of course, not robotic surgeon, everyone, but we have to consider the patient to experience debulking surgeon. So sometimes, so it depends on this hospital, and then so it is same question.
Yeah, according to the schedule, we have 5 minutes for discussion. So any question from the floor? If you have any question, just use your microphone.
Or you can type in the chat box if anybody
Okay, we
like to pose any
we will have same topics, two more speakers. So after complete the two speakers, let's discuss.
Sure.
Yeah, it's a good idea to have a discussion after all the three talks. So now we will move to, thank you, Jim, and we'll move to the next talk. And let me hand the chair to my colleague to introduce the next speaker.
Thank you, Dr. Lai.
Yeah.
I would like to introduce next speaker, Dr. Arunava Roy. Dr. Arunava, are you here? I don't see him here.
Is the next speaker there? Kayu is there?
Yes, I'm here.
Oh, you finished your surgery. Good.
Oh, yes.
Then I think we can go ahead with her talk.
Sure. Thank you, Dr. Kayu, for filling in.
Yes. So I recorded my lecture, but maybe it's better for me just to present it real time. So let me share my screen.
Let me introduce Dr. Kayu until then. She is going to talk on the current evidence on the use of robotic surgery in advanced or recurrent ovarian cancer. And Dr. Say is a clinical associate professor in the Department of OBGYN at the University of Hong Kong and an honorary consultant at the Queen Mary Hospital in Hong Kong and HKU Shenzhen Hospital. She received her GYN oncology training in Hong Kong and in UK, and she's keenly interested in developing training programs, ensuring quality assurance, and preventing surgical complications in robotic surgery. And she's a board member of the Asian Society of Gynae Robotic Surgeons. Over to you, Dr. Singh.
Okay, thank you. So you can see my slide, right?
Yes, we can.
All right, okay. Thank you, Professor Ruma, for inviting me to give the talk. And so actually, I presented a similar topic in Taiwan just a month ago. So for those who have listened to the talk, sorry that you have to listen for the second time. And so this topic is important because it is related to some medical legal issue. Just recently in Taiwan, there's experienced gynecologist being sued by the patients who has advanced and also recurrent ovarian cancer, and then she developed recurrence afterwards. And then she sues the doctor for performing robotic surgery on her because it seems that there's no good evidence on the use of robotic surgery. So that's why I think that we need to revisit the evidence in this topic. So I will divide my talk into two parts. One is on primary setting and the other is on recurrent setting. In primary setting advanced ovarian cancer, I think a lot of you will agree that it's very important for us to complete the debulking during the surgery. And there's many evidence to say that for those patients who have no gross residual disease, they have much better PFS and also overall survival compared to patients with residual disease, even they are just very small. In fact, there are a number of tools that can help us to predict the likelihoods of complete recession. For example, there are some articles investigating the roles of some demographic features like BMI, age, albumin level, performance score. Obviously, radiological assessment will be very important, and we'll talk a little bit on this later on. Tumor markers, the most important will be CA125. People have looked into the roles of like the baseline CA125 and also helium, a very hot topic nowadays. And some will also consider doing a diagnostic laparoscopy first to calculate, for example, the faculty score before proceeding to laparotomy and the debulking surgery. And because of the advances in AI, there are other novel techniques as well, like the use of radiomics to predict the likelihoods of complete recession. Now, the question is whether robotic surgery or other minimally invasive surgery will be able to allow the surgeons to complete the recession. As I mentioned, there are many scoring systems. So one of those that we commonly use is the Memorial Sloan Kettering scoring system. And it's based on some CT findings. And one of the most important will be the lesions over the roots of the small bowel mesentery. And basically, we also use this almost clinically to assess whether the patient will be able to have a complete recession before we attempt to operate, before we consider whether we can do a robotic surgery or whether we need to open the patients up. Now, TRUST trials, so some of you may be familiar with, it is a phase 3 randomized trials for patients with advanced ovarian cancer, and then they randomize the patients into laparotomy, the traditional method, and primary surgery, and also the patients with neoadjuvant chemotherapy, followed by interval debulking surgery. And what I want to draw your attention is that in this trial, which is a phase 3 randomized trial internationally, and the gold standard of the operation is still laparotomy, it's not MIS. So this gives us a hint that so some surgeons actually do not accept minimally invasive surgery in this setting. When I prepare the talk, I look at the literature, and honestly, there's not too many articles in this area. So one of the literatures that I could find is one abstract by Dr. Peter Lim. So all of you, or some of you may know him very well. And his abstract presentation almost 2-3 years ago. And in his preliminary series, there were 12 patients who were presented with ascites and also omental kick. So that means the patient have at least stage 3C tumors. And he used robotic surgery as the primary tool for the primary debulking surgery. The successful rates for optimal debulking was 75%, which was actually quite similar to laparotomy, so which was in the range of like 60 to 80% in most centers in the world. And the conversion rate to laparotomy is about 16%. And in his series, for each patient, the average numbers of procedures that were involved will be around 4, including like modified posterior exaggeration, file recession, and diaphragmatic stripping. In terms of the perioperative complications, you can see from the tables that, in fact, there were no obvious intraoperative complications, and there's no ICU admission. The median blood loss is around 200 mils, which was very acceptable, and the median operative time was just about 4 to 5 hours. And for the number of stays of hospital, for those patients who require surgery, the bowel resection, the length will be longer compared to patients without bowel recession, which was just about a day. So you can see that in expert hands, in fact, robotics-assisted primary debulking surgery is at least technically feasible, and it appears safe. And then, in fact, in primary setting, most of the evidence will be in the situation when the patient receives neoadjuvant chemotherapy. So there's recently one review article trying to look at different case series and so on the roles of robotic surgery in interval debulking surgery. And then in the article, I summarized that, as you can see here, there are only just a very few prospective trials, and then most of the trials are just like at the very preliminary stage, they're just single-arm, non-randomized trials. And so one of the most important one will be the LENS trial, but then at least at the moment, we just have the feasibility data. And so in the preliminary experience, which included only 100 patients with stage 3C and 4 ovarian cancer, all these patients received 3 to 4 cycles of neoadjuvant chemotherapy. And then the patients were randomized to either laparotomy or MIS approach, which could be either laparoscopy or robotic surgery. And in this trial, there were 3 successful criteria before they would proceed to the genuine phase 3 trial. So these successful criteria include a high accrual rate, more than 5.6% at the last month of the recruitment. The conversion rate should be less than 25%, and the rates of complete recession between the 2 arms should be less than 20%. And in this trial, the key inclusion criteria will be that all the patients should have resolutions of the disease outside the abdomen and also the pelvis, and the patients should not have excessive pleural effusion. CA-125 should be normalized, and then they should have a good performance score. And the key exclusion criteria were that the patient could not undergo MIS. So from my point of view, there's a little bit selection bias, but that it is this real-world situation. So here are the preliminary results. So the accruement rate was quite good, about 6 patients per month. And the conversion rate was just 12.5, just like half of their expected rate. And then in terms of the successful rates of complete recession, or what we call the CC0, the difference was just in the matter of like 4.5% point, so which was also within the acceptable limit. So now they are just proceeding to the phase 3 trial. Now, there's also recently another retrospective study which tried to look at the roles of CT scan in predicting the chance of successful cytoreduction during the MIS-assisted IDS. So in this retrospective study, there were only 87 patients, And you can see from the slide here that overall the accuracy of CT scan was quite good, about 70%. And then the false negative and false positive rate was about 30%. And there's a high concordance between small bowel and also mesenteric involvement. But then if the tumors were located around the diaphragmatic and also the perihepatic areas, then the concordance between the CT scan and also intraoperative findings was relatively low. And the authors postulated that the discrepancy may be because of the small tumor size, the size of peritoneum carcinomatosis, and also fibrotic changes, which make the radiologists have difficulty in interpreting the radiological findings. And then in our centers, our radiologists also performed a similar retrospective study, but we have smaller sample size. And she looked at the roles of contrast-enhanced CT scan in predicting residual disease after neoadjuvant chemotherapy. And in our center, most of the patients will have laparotomy for IDS. We just very occasionally use MIS approach for the IDS. And the sensitivity was quite good, about 90% with a very good accuracy as well, but there's problem with specificity. And similar to the previous study, in our series, we also have difficulty in identifying subdiaphragmatic lesions. And we also found that there's also difficulty in locating the tumors over the bowel serosa and also the mesentery as well. And I think that it might be because of the small size of the lesion, and especially if they are miliary with the fatty tissue around, then it's sometimes very difficult for the radiologist to locate the tumors. And also after neoadjuvant chemotherapy, sometimes there are some changes in the tissue structure as well. And so whether PET-CT scan will be better. In fact, our radiologists also had another study trying to compare PET-CT scan and also contrast CT scan. The accuracy was in both modalities were quite good, about 90%, with quite good positive and also negative predictive values. However, these two modalities also have some problems with sensitivity in certain extent. So it's given the hints that PET-CT scan may not be better than the conventional contrast-enhanced CT scan. And so earlier this year, there's also another retrospective study trying to compare the performance and also recurrence patterns between patients undergoing robotic surgery versus open surgery for the debulking surgery. And as you can see from the tables here, most of the patients undergoing robotic-assisted debulking surgery, they had IDS instead of primary debulking surgery. And so it's the number of patients or the proportions of the patient having the IDS was significantly higher compared to the open arm. So there's some selection bias here. And then also, if you look carefully, there's also a trend of having more patients using PARP inhibitor in the robotic arms compared to open surgery. So it might have some suggestion that patients undergoing robotic surgery, they seem to have smaller disease volume compared to patients with open IDS or open debulking surgery. And in terms of the procedures, so there's not much difference between the open method and also the robotic method. So there's similar rates of like diaphragmatic stripping, splenectomy, bowel resection, and also bladder cystectomy. And in terms of the operative complications, again, there's not much difference in terms of bleeding, bladder bowel injury, vessel injury, and also post-operative complications. So importantly, in this article, it shows that for the first recurrence pattern, it seems that there was very similar pattern between the open method and also robotic method. And so the number of recurrences in the abdomen, pelvis, and also beyond distally, they were very similar. And for the abdominal wall metastasis, again, very similar. And I will also talk a little bit on the pot cell metastasis later on. And for the survival outcomes, so it's quite interesting to note that patients with robotic surgery appear to have a better overall survival and also disease-free survival compared to laparotomy. So again, this might be because of selection bias and also the retrospective nature of the study. Now, for the pot cell metastasis after minimally invasive surgery, including like laparoscopy and robotic surgery, in advanced ovarian cancer, the incidence was up to 17%. So there's also another paper showing that the incidence was just about 1%. And the median time from the time from surgery to the development of pot cell metastasis was in the range of like 17 days, but then it could be as long as like over years. And for the risk factors for the development of pot cell metastasis, stage 4 patients appear to have higher chance of pot cell metastasis compared to stage 3 disease. And ascites was one of the risk factors as well, and it's not surprising to me. And although there's some limitations with the evidence that we have at the moment, but then the NCCN guideline also accept the roles of minimally invasive surgery during IDS, but not for primary debulking surgery. So that's why when we counsel the patients on the use of robotic surgery or even laparoscopic surgery in primary debulking setting, we need to be very careful. And we have to tell the patients that it may be outside the international standard. But then obviously there may be some other advantages of minimally invasive surgery like less blood loss and so on. So it's up to the patients whether they accept, but it's our responsibility to let the patients know about all these pros and cons. Now, in the recurrent setting, so for the roles of cytoreductive surgery in recurrent ovarian cancer, in fact, there's still a little bit controversies on that. There are 3 landmarks randomized control trials trying to look at the values of cytoreduction at the recurrent setting. And in the desktop 3 and also SOT1 study is a positive result supporting the use of cytoreduction during the recurrent setting. And then, but for patients under the GOG 213 trial, there's not much difference whether the surgeon performs surgery or not for patients with platinum sensitive recurrence. But then there's some criticisms about the patient selection under the GOG 213 study. And also the patient's population will be different, so we cannot really compare all these studies head to head. And for the SOT1 trial and also the desktop trials, they use 2 different methods to assess the likelihood of complete cytoreduction using the I-model score and also the AGO score. And for the I-model score, they use different demographic and also pathological features. And if the total score is less than 4.7, then it's suggested that the chance of having successful cytoreduction will be high. And so there's some old old meta-analysis, including some very small case series trying to compare the roles of MIS against open surgery. And then, sorry for the busy slide, but the conclusion is that in general, patients undergoing MIS for cytoreduction, they seem to have less blood loss compared to laparotomy. They have shorter hospital stay. And then in terms of perioperative complications, at least it seems that the incidence was quite similar compared to laparotomy. And then in terms of the survival outcome, it appeared that patients undergoing MIS surgery will be quite similar to patients undergoing laparotomy. And just quite recently, there's also another retrospective study published in Italy by our friends Valerio And it's retrospective studies, including 54 recurrent gynecological cancer patients. And then out of these 54 patients, 21 had ovarian cancer. And then all these patients had advanced diseases at the diagnosis, and then now they developed recurrence. And the median number of surgeries or previous abdominal surgery is about 2. And for these patients, regardless of the their cancer's origin, they had lymph node metastasis, peritoneal metastasis, pelvic, and also solid organ metastasis. And for the surgical procedures, so you can see that the recurrence operation involve different kinds of surgery like pelvic centration, bowel resection, splenectomy, liver resection, and so on. But despite the complexities of operation, the successful rate of CC0 was 100%. So again, in experts' hand, it seems that it is feasible. Now, in terms of the perioperative and postoperative outcomes, the median operative time is about 5 to 6 hours, quite similar to Dr. Peter's limb series at primary development surgery setting. Estimated blood loss was just about 100 ml, and there's not too many intraoperative complications and also vascular injury. And for like late post-operative complications, again, the incidence was pretty low, less than 10%. And the median length hospital length was just 5 days. So, and then looking at the survival data, the overall recurrence rate for the whole cohort, including all diseases, was about 50%. So for ovarian cancer, it's 52%. So actually, it was quite compatible even without surgery. And for the median disease-free survival, 20 months, median overall survival, 48 months, and the PFS and OS at 2 years was around 40% and 72%. So it's not a head-to-head comparison, but then in the desktop study, which used laparotomy for their cytoreductive surgery at recurrent setting, the median DFS was 18.5 months, which was very similar to the Italian series. And then for the median overall survival in their series is 55.5 months, and it can be up to like 62 months if complete recession could be achieved. But then for the desktop studies, it just included patients with ovarian cancer, whereas for this in Italy study, it's included patients with all gynecological cancers. So now I'm going to share some cases with you. And so for the first patient, she's a 51-year-old lady. She enjoyed good past health. At the beginning, she had just stage 2B of early stage clear cell ovarian carcinoma. And she underwent THBSO and full staging followed by chemotherapy. And then after more than half a year, she recurred. And the CT scan shows that there's an isolated 4-centimeter tumor in the abdomen, which was quite close to the ascending colon, and it seems that it's extended to the ureters and also IVC. So before we operate, here's the CT scan. As you can see that there's a tumor over the right lower quadrant. I'm not sure if you can see my mouse or not. And so before we operated, we calculated the I model and also the AGO score. So we highlighted all those cells that were applicable to her. And overall, the I model score was less than 4.7. And because it's just an isolated tumor, so we thought that it might be feasible for us to use the robotic surgery to debulk it. So during the operation, she had no ascites. The transverse colon was adhered to the anterior abdominal wall. And after bowel dissection, we found that there's around 4-centimeter cystic and solid tumor over the mesentery. And it's better than expected because it didn't extend beyond the pelvis, it extend beyond to the ureters, as shown by the CT scan. And there's just small, very small areas of small bowel serosal tear, which could be easily repaired, and there's no residual disease. Whole operation took around 1.5 hours, and the patients left the hospital after 3 days. And here's the video. So you can see that there's just a very tiny tumor around the mesentery, but it's very close to the bowel. So we need to be very careful during the bowel handling. And we try to grab only small piece of fatty tissue, not exactly on the bowel. So let me try to move this forward. Okay. And then at the end, we found that there's small areas of serosal tear. So we repair it robotically. So now I learned that we should take serosal tear very, very carefully after the surgery today myself. Okay, so next slide. Okay, so after the operation, the patient received 6 more cycles of chemotherapy by using carboplatin and gemcitabine. And after 6 cycles, there's no new lesion. Unfortunately, 6 months later, very similar to her last episode, she recurred. And so there's another tumor over the right pelvis and also some parietic lymph nodes as well. So whether we are doing her any good by performing the robotic surgery, I have no strong answer on that. And she returned to the Philippines for further management. So for the second case, it's a little bit more tricky. She's a 63-year-old lady and having stage 4 ovarian cancer at the beginning, and she had somatic BRCA2 mutation. At the beginning, she received 4 cycles of neoadjuvant chemotherapy followed by interval debulking surgery, and she showed excellent response to the chemotherapy with chemo response score 3. 3 means good. And she received 3 more cycles of chemotherapy followed by olaparib maintenance. And after more than 1 year, she recurred, and she presented with pulmonary embolism, and she's on apixaban. So in this PET CT scan, it shows only very few tumors only. There's one main one was in the peritoneum over the right side, and also another one just above it. The omentum was a little bit thickened, quite non-specific. And there's also another 5 millimeter right paragonic gutter nodule. And we reviewed the images with our radiologist before the operation. And on the left-hand side is the baseline scan before at her diagnosis, which showed multiple metastases. And after before IDS, after the neoadjuvant chemotherapy, most of the disease disappeared. And after chemotherapy, before she recurred, there's no new lesion. And then now at the recurrence, so you can see that it seems that there are only minimal tumors. And so one big one was over the peritoneum and another one just slightly above it. So we calculated the I model score and AGO score again, and the I model score was less than 4.7. So during the operation, there's no ascites, there's extensive adhesion between the small bowels and also the anterior abdominal wall. And surprisingly, there were more tumors than expected, multiple tumors, all around from 0.5 to 1.5 centimeter around the peritoneum and also omentum. And during the operation, with some debates amongst ourselves whether we should proceed with robotic surgery or whether we should convert to laparotomy. And then at the end, we proceeded with robotic surgery because of a few reasons. So first, there's no guarantee that we could achieve CC0 even after laparotomy because there's too many miliary deposits. And then another important reason was that the patient was on apixaban. By performing laparotomy, she may have more blood loss, she will stay in hospital longer with longer recovery time, and that may delay her chemotherapy as well. So that's why we thought that we might be able to achieve at least optimal debulking with the robotic surgery. And intraoperatively, there's no major complications. And it seems that we debulked all the major tumors, but again, we are not sure whether there's any hidden miliary disease. The whole operation took about 5 hours, mainly to dissect the bowels and also to inspect whether there's any residual tumors. The blood loss was minimum, and the patient stayed for 5 days after the operation. So this is the video. So you can see that there are multiple bowel loops hanging around, adhering to the overlying abdominal wall, and there were lots of small peritoneal deposits. Oh, sorry, let me move it forward. So because of the close proximity to the bowel, so sometimes we just try not to use too many energy source by we just do the cutting. And we spend a lot of time in doing inspecting to see whether there's any small tumor left behind. And we have to retrieve all the tumors from time to time so as not to mess around and then leave behind some resected tumors in the abdomen. And so we perform some piecemeal peritonectomy and also some omental biopsy as well with tumors. Okay. So, and then after the operation, she received 6 more cycles of carboplatin and paclitaxel. We did not give bevacizumab because of history of DVT. And so after the operation, her CA125 was around like 100 to 200, so which might be because of some residual tumors or maybe because of her pulmonary embolism. And so in the latest CT scan in April, it shows that there's some thickening in the omentum and paragonic gutters. But honestly, because of the experience with the PET CT scan, we're not 100% sure whether the patient will have any occult metastasis or not. And we are going to have another scan for her later on. So the take-home messages for this talk was that robotic debulking surgery in advanced and also recurrent ovarian cancer, at least technically feasible in good hands. But so far, the evidence was just limited to case reports and small case series. There might be more evidence on the use of robotic surgery in interval debulking surgery. But then even with the prospective trial, there's also some limitation with these, like most are single arm and also and then for the lens trial, it's just a feasibility. We just have the feasibility data. So obviously, we will need more research and more real-world data. Especially, we need more data on the oncological safety. And so that's why it's so important for us to counsel the patients thoroughly during the counseling. So I would like to take the chance to invite you to attend our virtual radiological workshop. So despite we have a bad experience with the PET-CT scan in our second case, I think it's still very important for us to read the CT scan and PET-CT scans as a surgeons ourselves. So it's not very common to have case of workshop, including a panel of different radiologists to teach us again how to read the anatomy. And then the recognitions of postoperative complication is very, very important. So we, as surgeon, we make complication, but the most important things is to recognize them early and to know how to deal with them. So this is the third time that we are holding such course. And followed by that, it will be our ONG Society ASM. So I invite all of you to come to Hong Kong to visit us. So thank you very much.
Thank you so much, Dr. Kayuse, for that excellent presentation. And it's very interesting, especially to see, how far we can push the boundaries of robotic approach in ovarian cancer. So it's also heartening to see that there is evidence that in terms of survival, whether it is a progression-free or overall survival, it's pretty comparable in most of the approaches that were taken. Although we have far and few studies and mostly retrospective in nature, but it's still heartening to see that. So if, I was to ask you to give our audience some, couple of red flags as a surgeon that they should abandon robotic surgery while doing the cytoreduction for ovarian cancer, what would they be?
Well, I think one of the thing is we try not to be that heroic, I would say. So we have to know our limitation. And so just now, Professor Lai asked Jim what is the expertise that we should have before performing robotic surgery in ovarian cancer? I would say that we should not take it, we should not do it routinely, I would say. Unless if you are like Peter Lim or Valerio, who are doing this all the times. But otherwise, we have to be honest with ourselves. So I think unless if it is like the first case is isolated tumor, then I think we will be able to proceed to robotic surgery. Like for our case, the second case, well, honestly, if we know that she has so many metastases at the beginning, we may even have to give up performing the cytoreduction rather than proceeding to the operation. But then it's just that we are now on the bench and we have no choice, and it may be better for us to just proceed with robotic surgery before doing any further harm by performing laparotomy.
Right. Thank you so much. And much of the encouraging data, it comes from, centers of high volume and highly selected patients that you need to begin with. So it's important that the wider GYN oncology community is extrapolating those outcomes, and it needs to be done with a pinch of salt by understanding their own capabilities around the technology and the technique that they're using. So I opened the house for questions if anybody has any questions or comments, and my co-chair, Dr. Lai, if he would like to comment.
Yeah, thank you, Ga Yu, for such a interesting presentation. Indeed, we recently just finished some robotic surgery in oligometastasis of recurrent ovarian cancer. And we use CT scan, PET scan, and now we are using ICG dye, intravenous injection, and to look for recurrent tumor lesions. And we found that the intravenous ICG injection may help to identify suspected recurrent lesions during operation. So maybe next time you can try it. Just inject 1 cc ICG dye, and you can see the fluorescence during 1 or 2 minutes. So we almost missed one big lesions behind the mesentery until we used the ICG dye, and we see something wrong there, some blue green fluorescence there. So I think in selected patient, in oligometastasis patients, yeah, it's feasible to do it by robot. But it's better to do achieve the R0 resection, and we routinely use PET CT scan and also use ICG dye during the operation to achieve the R0 resection. Yeah, that's my comment.
So
Maybe
it's
we
like,
can collect all these limited cases together and to see the outcome. We have patients survive more than 6 years after recurrence of ovarian cancer after resection. Yeah.
right. So when you talk about ICG, in fact, we have also tried this before, just one or two cases using intravenous ICG, but it seems that everywhere was stained in green. So that's why we didn't do it routinely. So maybe we have to modify our technique later on.
Yeah, it before dissecting anything or when you do the adhesive just try to keep it dry and before massive dissection, just check the ICG fluorescence. Yeah, otherwise it will turn green everywhere.
Yeah, I'll just make a comment here before the next speaker starts. I think it's an excellent thought that you have just come up with, Dr. Lai, that instead of having isolated case reports from here and there, maybe a series of cases with this kind of outcomes and survival will actually go again a long way in a lot of people in Asia to follow and do this with a little bit of more confidence as to what we expect by using this technique and technology for ovarian cancer, because we are moving towards there. Data would help.
Yes.
Thank you.
So I think the point that you made regarding usage of ICG, especially in the recurrent setting, I think that helps much more, because in the interval debulking setting, a lot of things appear green and it becomes difficult. But I think it's a very good idea to do it in recurrent settings, especially before you do any dissection, because most of the time we see plastered abdomens. So before we do much of the dissection, just putting in the dye, I think that's an excellent idea. So I think we have one question in the chat box.
Yes.
It's for you, Dr. Kayu. In case one that you discussed, why was Taxol not used?
Well, I think because the patients had recurrence between 6 to 12 months, so in our units, we called it partially platinum sensitive. If the patient had platinum-free more than 12 months, we usually will challenge with carboplatin and paclitaxel. But then it's just 6 months, so just follow the ocean trials using carbo and gemcitabine. Sometimes we use carbo and calyx as well. It's just because of the cost matter.
Right. So I think thank you. We don't have any more questions, and we should move on to the next session. And I request Dr. Lai to introduce the next speaker.
Now we are moving to our next speaker. Dr. Arunava Roy. If I pronounce this wrong, just correct me. Dr. Arunava Roy is a senior consultant in GI oncology and robotic surgery at a medical hospital in Kolkata. He is also the head of GI oncology department. He has over 15 years of experience in this field. After obtaining his postgraduate in OBGYN, he went on to pursue clinical fellowship in GI oncology at the Tata Medical Center. He is the best robotic surgery doctor in Calcutta. He was trained in basic robotic surgery in USA and advanced robotic surgery in Belgium. He is the first and only robotic surgery trainer in Eastern India and has been accredited by the European Society of GYN Robotic Surgery, means SEARCH. Okay, in the following, let's welcome Dr. Roy for robotic staging for early stage ovarian cancer. Let's welcome.
Thank you. Thank you, Dr. Lai. Thank you for the introduction. A lot of things have changed. I am no more the only one now in Eastern India. So that was the older version of my CV. Anyways, there are many good consultants with me now who are working at a very good level in Calcutta. First of all, my apologies. I was caught up in a surgery, so I had to change my slot and present next. I believe I'm clearly audible.
Yes, you
Yeah.
are.
Yes.
Yeah.
Yes.
So, thank you, ASGRS and AGRS for this opportunity. And yes, robotic surgery in ovarian cancer uh, is a topic which is very close to my heart, and I have been asked to speak on early ovarian cancer. I'm starting screen share. Uh, just a minute. Yeah, I'm just trying start share. Start share screen. And it's coming everything on your screen. It's screen broadcast. Zoom.
You can just share the desktop.
I am on my iPad. Can you see anything on the screen now?
The screen is broadcast and running.
Yeah.
Dr. Aruna, why don't you try it from some other device, maybe your phone or laptop?
No. It's I use my iPad as a laptop, and this is where I do every meeting from. I'm sorry.
So is there any technical guy online that can help?
Cloud share, camera, photos, Microsoft OneDrive, Google Drive, screen sharing. It just happens so easily every time. And everything on your screen, notifications required. Enable do not disturb to enable screen broadcast. Start broadcast. Okay. You are sharing screen. Yeah. Can you see my screen now? I'll
Yes,
just
yes. Just go ahead.
Yeah, now we can see.
Yeah. Is it visible?
Yeah. You can see that.
Yeah. Thank you. So it's evening 6:30 here, and I believe it will be late evening. So it's time for some good coffee and small talk. So let's go ahead. So see, ovarian cancer has the highest mortality among all gynecological cancers we all know. And whatever way we are doing surgery or approaching a ovarian cancer patient for surgery, our only aim should be that oncological principles should not be diluted. Be we are doing it open, lap, or robotic. It is very important to maintain that we should maintain all the oncological principles of surgery and should not dilute it for the purpose of doing minimally invasive surgery. It's very important to understand. So the role of robotic surgery is continuously expanding, and for ovarian cancer, these are the indications which we are using it for staging of apparently early stage ovarian cancer, which I am going to speak on. Completion surgery, where ovarian cancer has been detected after ovarian cystectomy or prior surgery like hysterectomy BSO. Assessment of disease extent and potential for resectability. Sometimes we do it. Abdominal inspection for resectability in open surgery. We use the scope only. Selected cases of interval debulking surgery in advanced ovarian cancer, which my previous speaker has already spoken of, and definitely which Dr. Lai was speaking, secondary site reduction in oligometastatic recurrence. So this is the entire arena in which I have been using, or we are using, ovarian robotic surgery in ovarian cancer for. So what are the limitations of robotic surgery? One, we can have port site metastasis, tumor dissemination due to cyst rupture. It's a major concern in early ovarian cancer. Incomplete staging, because we are not, we could not estimate the extent of the disease in a primary setting, and we could not do a complete cytoreduction. That's one. Inability to palpate the retroperitoneum for enlarged node or bowel for infiltration. That's how we do in open surgery. After the Lions surgery, Lions trial, mainly in advanced ovarian cancers, we palpate the nodal basin or open up the nodal basin and look out for enlarged node and debulk them. And for the bowel, we look, when there is a bowel nodule, we try to palpate and feel whether it has infiltrated the bowel serosa or the mucosa. But here, due to the lack of tactile sensation, we cannot do that. That's a drawback. And in case it may be very hard to assess, hard to reach areas like the gastrosplenic ligament, lesser sac, the porta area, the foramen of Winslow, the upper recess of the lesser sac. These are very hard to reach areas, which may be even in open surgery. So initially in your learning curve for advanced for ovarian cancer surgery, these are areas which you may find difficult to enter and look into. So what are the robotic surgery procedures done for early ovarian cancer? Hysterectomy, BSO in a young patient who is desiring to preserve fertility or has a germ cell tumor, you can do fertility preserving surgery. Pelvic lymph nodes, parietic lymph nodes, total omentectomy, and uh, selected peritoneectomy in patients if there is small amount of peritoneal dissemination. So what are the evidences that exist for early ovarian cancer staging in robotic surgery? This is a paper from 2015, which was a review article by Lucas Minnick et al. And they suggested that robotic assisted staging in selected patients with early disease has an important role in referral institutions and should be performed by trained gynecologists or gyneco-oncologists. Then came this evidence in 2017, which was again also a review article by Anna Fagotti et al. And they mentioned that robotic surgery seems to be safe and feasible for early stage ovarian cancer. And its use in treating patients with advanced ovarian cancer is still highly controversial. But this was 2017. There has been many evidences in advanced ovarian cancers after that, which has been already discussed in the previous presentation. And then in 2023, Dr. Philip Van Treppen from Europe gave us this article where he looked into the feasibility of robotic surgery in early and advanced ovarian cancer. What was the case selection criteria and for surgical staging and interval debulking surgery? And he suggested that patients with clinically early stage ovarian cancer confirmed after a laparoscopic removal of suspicious adnexal mass followed by a prosection are candidate for robotic staging surgery while maintaining similar surgical and oncological measures as open staging surgery. And, we are moving to an extent. So the main idea of doing a surgery for a seemingly or presumed complex ovarian mass, which can be malignant or early ovarian disease, is basically the reduction in morbidity of a major open surgery, reduction in blood loss, hospital stay, pain, and maybe attending adjuvant chemotherapy at an earlier date. These are the main ideas. And nowadays cosmesis is also coming into a role, and maybe that's why this paper in 2026 in the International Journal of Gynae Cancers came out, which is a very recent paper, where they have looked into the feasibility and surgical outcomes of a single port robotic surgery for early stage ovarian cancer. So that you can go into this and look into the primary results. This is a pilot study, and they have mainly tried to establish the feasibility and safety of this doing this in early stage ovarian cancer. So this is where we are moving into minimal invasive surgery. First, we are skeptical about doing minimally invasive, then from laparoscopy, we moved to robotic for early stage, and now we are trying to move into single port robotic for early stage cancers, mainly maybe in young patients who don't want to have scars in the abdomen. So and definitely also less pain because less number of ports. So this is again a paper by Anna Fagotti et al. So you can read the entire paper in IGJC journal. So what are my criteria for doing it? Well, single complex large mass, which is mostly cystic. Now, if you have mass which is single, limited to the ovary, but it is majorly solid, then you cannot decompress and take out the mass. So if you have to read your scan very nicely, you see that the mass is majorly cystic with some solid elements inside, which produces the doubt, and there is elevated CA-125 and also the ORAD score is high. That is where the cases will be stated. But if you have a mass which is majorly solid, then you cannot decompress the mass and take it out. So ultimately, at the end of this procedure, you'll have to open up the abdomen to deliver the specimen. So your main idea of doing a minimally invasive surgery is gone. So in that case, it's better to go ahead, do a laparotomy and go ahead with the surgery. Next is size up to 15 centimeter. I'll tell you why when I show you my video, because this is the size of cyst up to which my modified bag can accommodate. Anything above that, the present bag that I use cannot accommodate. That's why for me, the size is up to 15 centimeters. Number three is no dense adhesions. When you once first you put in the camera and see if there are dense adhesions in the pelvis with the rectum or maybe the side walls or the posterior wall of the uterus, then there is a high possibility that during dissection of the mass from the pelvis, there may be intraoperative spillage. So it's better to give up and go for laparotomy direct. No peritoneal dissemination or gross ascites should be there on initial estimation while you put in the camera. There may be, if you see a minimal dissemination like 1 or 2 nodules in the pelvis or here and there, that's okay. But if there is major peritoneal dissemination, gross ascites, then you should be a real expert in doing robotic primary debulking surgery, and that's no more an early ovarian cancer anymore. So the main concern is to avoid spillage. That's the main concern. That is where is all the questions come up, and that is where all the doubts and queries come up. Are we upstaging the disease? But I put a question to all of the surgeons who are hearing me out. Haven't you ever accidentally spilled in open surgery? Did it never happen? At least it has happened with me. Sometimes adhesions, very thin wall at a part of a cyst where you try, your assistant was pulling or you were trying to manipulate and it spills. So if you can have spills in open surgery, what is the crime of having one in a to deal a large ovarian mass in robotic surgery? So this patient is a 65 years old lady with CA-125 of postmenopausal, of course, with vaginal deliveries previous, no major comorbidities other than hypertension. She presented with a large solid cystic mass in the right ovary. The scan did not mention anything else in the abdomen or in the thorax. Her CA-125 was raised to 450, and that was a clinical presentation. She presented with feeling of heaviness in the lower abdomen. So, the main advantage of these patients, have these patients who have some cardiorespiratory or other health concerns which compromise uh, their capability of undergoing a major open surgery. Robotic surgery gives them fantastic recovery and discharge within a day. That is what has been my experience. You open up these patients, these are elderly patients, pain, they cannot breathe properly, they develop lung problems. Due to the pain, they cannot breathe properly, they have lung problem, and in spite of how much of spirometry or chest physiotherapy you do, sometimes they have a very poor recovery, and in them the wound healing is also poor. So they have sometimes wound complications also. So you can presumed to be early ovarian cancer due to the solid cystic nature. And the initial step after get into the abdomen is definitely a cytology. We take a cytology at the beginning and also at the end of the procedure. I'll tell you why we do that. So before you start the surgery, you can see it's a mobile, nice mass. These are the cases to be done, minimally invasive, not the ones which are densely adhered, bad masses stuck everywhere to the rectum and all. So it was a right-sided mass after the cytology is taken. We open up the right retroperitoneum about a centimeter parallel to the infundibulopelvic ligament on the right side. Skeletonize the IP ligament. You can see the ureter running down below. I believe the video is playing smoothly. If it's okay, just tell me yes. Is the video going on smoothly? Kanika? I'm
Yeah,
not
It's
audible.
okay.
it's
A little bit
smooth.
lag, but okay.
Yeah,
There is a
So,
bit of a lag if
yeah, okay, because it may be because of the internet. Yeah, you take the IP ligament, devascularize the ovary, and take the peritoneum right up to the uterus. That drops down the ureter definitely. So you go ahead and reach up to the uterus, but at this point you do not disconnect it from the utero-ovarian ligament because your patient is in Trendelenburg position, and if you disconnect it from the uterus right away, it will immediately fall into the upper abdomen and it will be really difficult to bag it. So this is the reason why I use a 15 centimeter. These are definitely modified bag. I use a normal Euro bag to do it because it is one of the toughest bag you have in store or at hand. And whatever amount of pull and tag you give to the bag won't tear away. It's very, very tough. That's why I select a Euro bag, and that's why the size of 15 centimeters. So after the mass is half inside the bag, then you take the utero-ovarian ligament and drop it inside the bag. That makes it much easier to bag this large specimen. Bagging should be very smooth because that is another arena where you may accidentally, spill the cyst. So it should be very smooth. And if it doesn't fit your bag, open up and do the surgery. So after many cases, I found that this is a bag which is suitable for my work and which is toughest. Other bags tore away when I was, trying to retrieve the specimen. This never gives away. And that is why the size criteria of 15 centimeters. You bag it, keep it in the upper abdomen. This is a woman who underwent a hysterectomy BSO. So after the hysterectomy was done, so a sponge holding comes in. I prefer natural orifice delivery. I do not try to extend one of the incisions. And once the bag is pulled out, and this is the vaginal view now. So we do a control puncture using a discarded, Varies needle, because if you make a prick with a scissor or with a suction, it will immediately spill out a large amount of fluid, but this gives a very controlled puncture without any spillage that is attached to suction, and as it decompresses the mass, you pull out the bag. It's very easy and simple to do. That's why I say if your mass is majorly solid, you cannot do this. In that case, please go ahead and do a laparotomy. Don't try minimally invasive, and don't try anything else to spill inside the abdomen or make the or upstage the disease. So that is how I deal ovarian mass, which is presumed to be early in early ovarian cancer in robotic surgery. And one thing which was not shown in the video is that as a part of this, I was doing a prospective trial on this method. And what I've done is that in all the patients, we did a pre-procedure cytology and a post-procedure cytology after the mass was delivered and the vault was closed, to get an evidence whether this method in particular is leading to any change in the peritoneal cytology of the patient, if at all. So this is our data till date. Of all the women that we did, some were young girls also with germline germ cell ovarian tumor, and there were elderly women with epithelial ovarian tumor. So we had 50 women who, all of the women that we did, not all of them were positive in frozen section, but this is a data of 50 women in whom the frozen section was positive for malignancy. The average surgery time was about 90 minutes, I will say about 2 hours in total. And mean blood loss was minimal. It was about 50 ml with a range of 30 to 100 ml. Median mean hospital stay was about 48 hours with a range of 24 to 72 hours. Time to adjuvant chemotherapy. Oh my God. Okay. Sorry. Time to adjuvant chemotherapy for all of these patients was less than in open patients. A lot of them went to meet the medical oncologist by 10 days and started their chemotherapy by 2 weeks. There was no difference in pre-procedure and post-procedure cytology of the patients. So that is very important. This is very important to understand here. That is why we did a pre-procedure and post-procedure cytology. That in the patients in whom the pre-procedure cytology was already positive, the post-procedure cytology was also positive, but in whom it was negative. So the patients who were inherently 1C because of peritoneal fluid positivity, they were positive in both pre and post-procedure cytology. But in patients who were negative in pre-procedure cytology, that means 1A, none of them were upstaged by this technique, and even the post-procedure cytology was negative in all of them. This is a small video again on a standardized steps of para-aortic lymph node dissection, because that is an essential staging procedure in early ovarian cancer. This is one of the indications where we do nodal dissection, unlike in advanced ovarian cancer where we do nodal debulking. So this is a standardized procedure of, just give me a minute. Just give me a minute. Just give me a minute. I am connecting it. Yeah. So this
video depicts 8 steps to comprehensive para-aortic lymphadenectomy, its indications, anatomical boundaries, considerations, preparation, port position, and message for surgeons who want to attempt it. Hi.
It's not playing, Dr. Arunav, if you can.
Not, the video stopped. So Dr. Roy? So we are losing the signal from Dr. Roy, right?
Yeah, I think he's speaking from the operating room, so
Yeah, I think it's about time. So okay, I think we can wrap up this session, and maybe we can have a few minutes for discussion if anyone have further question.
I think there's a question that has been posted in the chat box, and
Yes.
if Dr. Pike is here,
Yes.
can answer until then. And it says that, do you think robotic is better than conventional lab in terms of preventing rupture of the cyst? And if yes, what are the skills, tips you need to implement in the robotic platform? And is trying to not in basically about preventing cyst rupture. If question is basically if robotic is better than laparoscopic, and some tips that can be given in early ovarian cancers in suspicious masses.
Yeah. Is Jim still there? Yeah,
maybe
okay.
you can
I
give
think it's about
give
the
some tips,
technique.
Dr. Lai. Yeah.
The tips about how to protect the tumor from rupture. Yeah, it depends on the size, the adhesion, and the technique. So yeah, it's a principle to try to lower the risk of rupture, but we cannot guarantee 100%. If we can do it, without rupture if we do it open. So it's all it's the balance between risk of malignancy and the risk of and the benefit of MIS. So it's a big question. Yeah.
Yeah,
Yeah,
I
I
think
think
if I can just add to what you said, obviously, the right choice of patient is a must, understanding the patient. Then how robotic is better, how I find it to be better is because your arms are so much more stable while doing robotic surgery in comparison to laparoscopic. There is no inadvertent movement that can happen. And on top of that, another tips that can be given is to hold the masses through the ligaments rather than trying to touch the ovarian cyst surface, whether it is through the IP ligament, and you stay a little behind and go to till the edge of what you can see the IP ligament, so that you can pull the mass on the IP ligament. And again, while you are navigating around it, the robotic instruments are so much nicer to curve around the masses compared to the straight movements that we typically have in the laparoscopic arms. And again, holding the tip of the ovarian ligament as well.
yeah.
Arunav
Yeah.
has joined finally.
Yeah, I
Yeah.
got disconnected. Sorry.
Yeah. So I think yeah, I think it's late in Taiwan and Korea and Japan. So
Yeah.
the Dr. Ruma, do you
Yeah,
have close
I would
this
just like to
meeting?
add one thing. Can I share? Okay, I will share something very quickly with all of you. And this is just to bring everybody's attention to the social media pages that we have with ASGRS now. So I would like all the people who have joined us with it, thank you for taking your time out to be with us. And you can actually get information about our future programs on these social media pages. So please do join and be connected with us. The next ASGRS webinar will be on 19th of September, 18th of September, which will be the third webinar of this series. And that will be just talking about hysterectomy from standardizing to mastery. One session on benign and one on radical. So this is just a small information I wanted to share with all of you. And thank you, Dr. Lai and Dr. Kanika, for moderating this session so beautifully, bringing out the pertinent points. Dr. Jim, Kayu, and Arunava for giving excellent talks. I remember talking to Kayu at Taipei, and we thought we'll do a ovarian cancer webinar because this is upcoming topic, and we'll have a round ovarian cancer 2 point or second round in the month of October. Is that right, Kayu? Right.
Yeah.
So thank you very much, and good evening to all of you.
Yeah. Good evening. Bye-bye.
Good evening. Bye.
আরে বাবা, যখন কাটছি না বারবার, ডোন্ট কল ব্যাক আনলেস ইট ইজ আ লাইফ থ্রেটনিং ইমার্জেন্সি। আমরা ওয়েবিনারে ছিলাম,